I have just realised that I've been chatting to you all in mute for the last couple of minutes. Anyway, welcome everybody to the fourth CATS webinar. Today we're going to be covering Dicky Tickers, or essentially we're going to be covering heart disease in paediatric patients. I've got a couple of great speakers for you. Their talks are going to be interactive and covering lots of different areas. We're going to cover, first of all, acute heart failure in paediatric patients. And then after that, we're going to cover congenital heart disease or duct-dependent congenital heart disease in paediatric patients as well. As I said, the sessions are going to be interactive. We're going to be utilizing Slido, first of all, online, but also the chat mode in Zoom as well. So on the right-hand side of your screen, you should be able to see a QR code. What you can do is use the camera and scan that over the QR code, and that will take you directly to the session in Slido. Or you can go to slido.com and put the hashtag Dicky Tickers in as the event code, and that will also take you to the session. As you probably all realize when you've joined, your video and your audio should be automatically muted. But if for some reason you've noticed that hasn't happened, then please do mute your video and audio for the duration of the talks. You will be able to ask questions to the speakers throughout the sessions, either on Slido or via Zoom. If they require to be interrupted, I'll do that for you and moderate the sessions so that we can ask the questions as necessary. At the end, what we're going to do is give you a further QR code and a link to provide some feedback, because as you'll be all aware, feedback is helpful for us to try and make sure that we are delivering the education that we can to the best of our abilities. And then at the very end, what we'll do is we'll talk about certificates. So without further ado, I'm going to hand over to the first speaker. And the first speaker today is going to be Angela Aramburo. She is a consultant paediatric intensivist at the Royal Brompton Hospital. She's also a CATS consultant, and she's going to be speaking to us about acute heart failure. So morning, Angela. Thank you for joining us.
Good morning, Linda. Good morning, everyone.
Stop scaring now, Angela, and I'll let you take over sharing the screen.
Okay. Just to warn you, this is the first time I'm going to do this thing with the slide and the polling and voting, but bear with us. Hopefully things go well. I'm just going to start by sharing my screen. Hopefully that works. Okay. And hopefully you are able to see the presentation coming up now. Yes, all good? Perfect. So we are going to be talking about acute heart failure. Basically, I have based my talk around 4 cases. All of them are real cases, actually all pretty much recent cases. And they cover different aspects of the most important principles that you have to take in mind when you are dealing with a child with acute cardiac problem. Let's start with the first case. So you are on call in a DGH in A&E, and at 4:15 there is a blue call. They tell you there is a 4-week-old male that they are bringing to you with wheeze and increased work of breathing. At 4:20 the ambulance is there, and you get a very brief history. The child is 35 plus 6-weeker, spent 1 week in hospital for query sepsis. The child has been vomiting and refusing bottles for the last 2-3 days with increased work of breathing. And the GP saw the baby, prescribed some paracetamol with the suspicion of viral illness. The LAS crew has given some salbutamol because they felt that the child was wheezy and had obvious increased work of breathing. The respiratory rate is 64. They are actually, they say that the heart rate is unrecordable, but there is a query on the notes 190. The child is floppy, unrecordable temperatures, and unrecordable BM. Wait a second. So your initial assessment, this is 4:20, you just received handover. The child has a patent airway, but the child is definitely grunting with nasal flaring recessions. The respiratory rate is 36. The stats are unrecordable. The heart rate is 176. You feel femoral pulses, but are weak bilaterally. The child is cold with a capillary refill time of 5, and there is actually an unrecordable blood pressure. You think that the abdomen is distended, but doesn't seem to be tense. The child is definitely floppy, but the eyes are open, responds to pain, and there is a normal fontanelle. Again, for you, you can't record the temperature, and you don't see any obvious rash. You immediately, after seeing this baby, you immediately put a crash call on. This is 4:35 a.m. In the meantime, at 4:32, all these are real timings. Yeah, I'm not making anything up. At 4:32, just before the crash call, you have taken a gas, and you see that the pH is 6.5 with a CO2 of 8.5. Yeah, therefore, probably this respiratory rate of 36 is actually indicating you that the child is unable to compensate. So it's already a very important warning sign. You have a base excess of -34 with a normal HB, and your lactate is 17.39 here, okay, with a normal glucose, slightly high glucose. Potassium is 7, sodium is 127. When you see this crash call, and here you are like, okay, what is my differential? Probably you will have to include, at this stage, you are thinking, okay, what can it be? It probably has to be some neonatal cause for shock. That would include sepsis. I have to give antibiotics. I have to do my bloods. It could be cardiac, metabolic, non-accidental injury, acute abdomen, maybe a tension pneumothorax. I actually don't know at this stage. All right, then. So here we go with the first question. Let's see if this works. All right. Are you seeing the questions? Because, so Linda, I'm so sorry. I press play and I can see the question. Okay. So the first question is, if you could have one more piece of information, which one would you choose? Obstetric history, family history, presence of a murmur, liver size of ammonium. Okay, people are still voting. 10 votes going in, 16, come on. All right. Just going to wait for 2 more seconds. Okay, so it looks like the 2 most important questions that you would like to ask is either if there is a presence of a murmur, but probably that is because we are talking about cardiac, you know already that, or liver size. Very good. So I have to agree with, I mean, knowing if there is a murmur would be important, but before that, something very fast and very important that I would always want to know before I start resuscitating my child is if there is actually hepatomegaly on physical exam. And this child did have hepatomegaly. This child had a liver that was 3 to 4 centimeters. Okay, so this is at 4:35. Remember, you had put a crash call while people are getting in. You decide to take an ECG. This ECG was taken at 4:36 a.m. And I would like you to have a look. Sorry, there was one more question before we go to this ECG. I'm sorry. If a cardiac cause, if a cardiac cause, which one is more likely? Okay, left-sided obstructive lesion, arrhythmia, or acute myocarditis? 6 votes, 9 votes, 15 votes. All right. Okay, so almost half of the audience is thinking that a left-sided obstructive lesion would be the most common, the most probable. And the second most voted option here is acute myocarditis. Okay, just let me remind you about this question, that this baby is actually 4 weeks of age. It's not a baby who is 7 to 14 days old. Therefore, my first option definitely won't be a left-sided obstructive lesion, because I mean, it would be a little bit too late for a duct-dependent lesion to present at 4 weeks. 4 weeks, yeah? It's probably slightly later. Myocarditis, definitely, that could be an option. I mean, that happens. Sometimes we have even neonatal myocarditis. Mom can get an infection peripartum, and you may have that as well in the neonatal period. But I think the most common one in a young infant or a neonate, in terms of, 2 days history of increased work of breathing, refusing feeds, and then presenting in shock, I think you cannot rule out an arrhythmia as the cause, okay? And in this case, actually, people in A&E felt that this might be an arrhythmia and got an ECG at 4:36, and this is what you are seeing. Now we are going to, I think, vote again. What do you think about this ECG? And I give you options here. VTAC, AVRT, so atrioventricular reentry tachycardia, SVT, other, or it's actually impossible to know from this ECG. All right, votes are going in. The audience is quite divided between it's impossible to know, VTAC or AVRT. Okay, so looks like most people feel that this is not possible to know. And I actually would have to agree. There may be some things that you could think about that maybe will point you in one direction or the other between VTAC or SVT. But what we can see for sure is that this is a fast rhythm that is very regular, and that there is a broad complex. Yeah. So at this stage, we don't know if it's VTAC or it might be a sort of SVT, but we know that there is a fast arrhythmia here going on. Okay, that question, I think we just did it. Okay, so we will go through it later, but this I can tell you is SVT with wide QRS. And later we'll explain you why. So at this stage, you think, okay, this is likely cardiogenic shock. I don't know if there might be some underlying metabolic condition or sepsis because the child has very severe metabolic acidosis with very high lactate. The team started back valve mask ventilation, and they were trying to get access. At this stage, there is another gas taken with at 4:53 when the child is on 15 liters of oxygen. And here we see that the pH that was prior 6.5, now it's unrecordable, the same as the CO2, and the lactate has gone up to 20. So this is evolving. This is not good. The initial heart rate was 176, but that ECG that we saw was at much faster rate. So something has changed and something is actually deteriorating. You have now a 25 gauge cannula, you have given 1 dose of antibiotics, you request an X-ray, this is 502. And then at 505, you take again your vital signs. The heart rate is now 247, the respiratory rate is 40, and the blood pressure, the mean blood pressure is 39. So this child is tachycardic and hypotensive and peri-arrest at this stage with an unrecordable CO2 and pH. This is the X-ray. As you can see, there is a large heart. The lungs are congested. You have an NG in place, but this child is being bagged, and you have a massive stomach, which is not helping probably either, but this is where you are. And at 5:05, yeah, there is a discussion, the crash call team has come, and you have a discussion with the anesthetist regarding simultaneous need for intubation and possibly cardioversion, and which one should take priority. At this more or less same time where you're having these discussions, the SHO is asked to call CATS, which is what happens. So now we are going to vote again. In regards of this discussion that you were having with the anesthetist, what do you think CATS advise? Intubation first, cardioversion first, adenosine first? Okay, we have 10 votes, 12, 34 votes. Okay, I think adenosine is first now, cardioversion second. Okay, there's a lot of competition between cardioversion and adenosine, but some people think that intubation should actually be first. Okay then, so I actually was the CATS consultant that night. So I took the call, and what I advised was to cardiovert the child. However, because they had access, I said, okay, if you have adenosine ready to go and it's not going to delay cardioversion, you can go ahead and administer right away adenosine. But definitely your priority before intubating is cardioverting. You cannot have a child with a more unstable tachycardia. So, and I said as well, please have your resuscitation trolley ready and be ready afterwards to intubate. So I just want to briefly talk about the algorithm, the PULSE algorithm of emergency treatment of SVT, because this was a real case, and there was also quite a lot of discussion that happened after this case at the local. There was some outreaching, and then this case was actually presented in a CATS forum, because for the local team, it was quite difficult to decide, I should not tube, I should cardiovert this child without getting a tube. And it felt quite difficult for the team to decide to just shock the baby. So I just want to point here. Okay, so when you have a narrow complex tachycardia, in this case was white, yeah? Shock present, yes or no? If there is shock, you can potentially try vagal maneuvers, so, I mean, but this, if no delays. But the next thing that it says clearly, establishing vascular access is quicker than obtaining defibrillator, yes or no? If it's not deemed to be quicker, then you are supposed to shock the baby, so DC cardioversion. So no one in the algorithm says to intubate. They only talk about getting access or not getting access. If you have access and adenosine is ready and it's going to be faster than cardioversion, then you go ahead and give adenosine. If that's not the case, you are supposed to shock. And no one here, anywhere, it says get the airway first, okay? And this is the emergency treatment for ventricular tachycardia. Is basically, it starts the same. Is the pulse present, yes or no? If it's not, you go VF protocol. But if the pulse is present, yes, and the child is shocked, yes, you basically DC cardiovert. You had here this actually a scenario because you had a broad complex tachycardia in a very unstable child. So really there was not very much question. I mean, you could have tried adenosine, but definitely shock was the right answer, okay? So at 5:25, actually, despite I said, please cardiovert the baby, the team felt very, very uneasy with that. And they decided to intubate the baby. That was done by the anesthetist with fentanyl 2 micrograms per kilo and ketamine 0.5 milligram per kilo. So, and this is the gas post-intubation. Again, we have an unrecordable pH with a lactate of 18. And now we are just going to go to the next question, I think. No, that's that. Okay, so I just want to highlight a few things about the intubation in this baby. First of all, the risk of this child arresting while intubating is extremely high. Basically, the child is already peri-arrest, yeah? And probably the child has tachycardia-mediated cardiomyopathy. We know that there is a very large liver. The child is completely unstable with unrecordable pH. So you really have to be prepared before you intubate. So these cardiac cases are cases where actually you need to optimize the circulation before obtaining A and B. In this case, optimizing implied cardioverting. And also, the child is already in a very severe low cardiac output state. So you have to be extremely, extremely cautious with the sedation that you give. Very, very little is enough, if any. And I actually advise here just to give 1/4 to 0.5 milligram per kilo of ketamine. Still, there was that the anesthetist felt uneasy with that and gave 2 micrograms per kilo of fentanyl in addition to that. But I mean, it is actually everyone's responsibility to discuss this before obtaining the airway, because the last thing that you want is that you have not cardioverted the baby, you give the baby induction agents and the child arrests. Yeah, okay, so that's that. And this finally 5:30 a.m. the child is tubed, and then there's 100 micrograms per kilo given to the baby of adenosine, and there is no response. You see here that we see the little arrows because we are synchronizing the QRS. And here I also wonder, okay, if we had already the pads on, how come it was, difficult for the team to decide on cardioversion because they were all ready for that. But then after the 100 micrograms per kilo at 5:38, they give a second dose of adenosine at 200 micrograms per kilo. And with that, the child reversed to sinus rhythm. This already gives you the diagnosis that this was not VTAC, this was a broad complex SVT. So the child was transferred to Brompton by CATS, intubated on adrenaline infusion after cardioversion because they felt that the child was still in shock, despite was better. Very little IV fluids, as you can see. During the whole resuscitation, the team was very good at that, only 12 milliliters per kilo administered. The echo on admission, the child had mildly depressed LV function. You know that when you cardiovert them and they go back to sinus rhythm, the function recovers quite fast most of the time. But the baby did develop acute kidney injury grade 3, was extubated on the day 4, and then was discharged in 2 weeks. But after discharge, the child was readmitted to Evelina ICU with worsening acute kidney injury, and the child actually required PD. So this child truly had very severe shock that had some consequences afterwards. Okay, so briefly, there are 3 mechanisms for tachyarrhythmias: reentry, automaticity, and trigger activity. This is a case of reentry, which is the most common one. Basically, just to remind everyone, for reentry to happen, there has to be an accessory pathway, and this accessory pathway must, the 2 pathways, they have to have different refractory periods. So normally, this starts by a premature beat that finds the normal pathway ready to conduct. But however, the accessory pathway is in refractory period, and therefore normally this doesn't start a reentry circuit. However, when there is a premature beat, then this second pathway may be not in refractory period and ready to conduct retrogradely, and that's how the reentry circuit starts. Okay, so there is normally always a premature beat that starts this pathway. And there are 2 main types of accessory pathways. This accessory pathway can be atrioventricular, so that is what we call AVRT, or it can be in the nodal, in the AV node. This is more common in older children, and this is very common in infants, even neonates. And this accessory pathway can either conduct antegrade or retrograde, or only retrograde. Okay, and this is important because if it can only conduct in a retrograde direction, this will be a concealed pathway. However, when it can conduct also in antegrade direction, this is what we call Wolff, Parkinson, White, and that gives you pre-excitation. But as we said before, SVT can present with wide QRS. And there are 2 main scenarios where you can have wide complex QRS SVT. One is if there is aberrant conduction, and the second one would be if there is pre-excitation or antidromic AVRT. Aberrant conduction can either be pre-existing, so imagine that the child, for whatever reason, has had a tetralogy of Fallot repair. Very commonly after that, they have right bundle branch block. So the child already has an aberrant conduction. So if this child goes on SVT, then it will not be a normal narrow QRS SVT. It will be broad because there is already pre-existing right bundle branch block. And also, just due to the fast rhythm, sometimes during the tachycardia, children develop bundle branch block. So that is called rate-dependent aberrancy. So you can have only broad complex SVT, or you can actually have narrow complex that develops into broad complex, and sometimes the broad complex goes back, and during the same tachycardia, you see that the QRS narrows again. So that is called rate-dependent aberrancy, which is probably what this baby had, because when we had sinus rhythm, the sinus rhythm was normal, yeah, so there was no bundle branch block. This rate-dependent aberrancy, most of the times, actually take the image of a left bundle branch block. So how do we differentiate these 2 from VTAC? So actually, if you have time and the child is not hemodynamically unstable, if you give adenosine will terminate AVRT. However, it would not terminate VTAC. But again, if unstable, please DC shock. And this is exactly what we had. This child had SVT with aberrant conduction, left bundle branch block, with positive here S waves in V6 and negative in V1. Okay, so this is very typical. So another important point about how to make the diagnosis of SVT is how the tachycardia terminates. And that's why we always advise you to have a rhythm strip running before you give adenosine. And AVRT, because it starts with a premature beat, then it conducts normally antegrade through the AV node, and then it goes backwards through the AV, through the accessory pathway. Most of the times when you give adenosine and you block the AV node, then this retrograde, this cycle goes back, there is a retrograde P wave, but then that P wave cannot be again conducted down to the AV node because you have blocked the AV node with adenosine. Therefore, normally it terminates with a P wave. So if you see a P wave terminating after adenosine D tachycardia, you also know that this was SVT. And actually, this is what we had here. You have the P waves here, and actually this terminates with a P wave. Yeah, and then you have normal sinus rhythm. Very good. Just briefly about adenosine, remember that despite the guidelines say 100 micrograms to start, most of the times actually at the Brompton and our electrophysiologists, they do recommend 200 micrograms per kilo. Be ready to resuscitate the baby, yeah, so because sometimes you can have prolonged asystole after adenosine, or you can have hypotension, or even induce AFib if the child has worked Parkinson-White. And remember to use a stopcock and a fast push and fast larger flash with an IV line closest to the central circulation. So just before we finish this case, timeline. Remember, just this is exactly what happened. At 4:20 a.m., it was the first assessment in A&E. And however, the team was working super hard and really well as a team. In fact, it was not only until an hour and 18 minutes later that the child was converted to sinus rhythm. So for me, take-home message from this is with a sick child, time flies. So it's very important that you are in control of that. If there is hepatomegaly, think of the heart before you start resuscitating, caution with fluid boluses, and please very cautious with intubation drug. Optimize first your circulation. Know well what you are treating and know the algorithms. And don't be afraid to follow the algorithms. Again, if there is an unstable tachycardia with a pulse, it doesn't matter wide or narrow, you must DC shock, unless you want to continue treating a child in shock. Okay, nowhere in any algorithm it says intubate first. If broad complex tachycardia and child is stable, adenosine can help you to differentiate SVT versus VTAC. All right, so that was the first case. So let's move to the second case, something different. This is a 9-year-old girl, previously healthy, who presents to A&E with severe abdominal pain. The child has a 4-day history of abdominal pain and fever, sore throat, and vomiting. The child has been seen by GP, who has diagnosed tonsillitis, and antibiotics have been prescribed. On your first assessment, the vital signs as a heart rate of 111 with a respiratory rate of 29, the child is tachypneic, saturations 94% in air, blood pressure 85/40 with a capillary refill time of 3. The child is slightly cold, alert, but very tired looking. And your first impression is that this child may have appendicitis. However, while you are trying to reach your surgeons, getting an X-ray, getting labs, the child suddenly becomes pale, distressed, and complains of central chest pain. You put a resus call and you continuous monitoring, and you put continuous monitoring on. Someone gets an IV access, actually 2. Bloods are taken, cultures are taken. You do a venous gas, cross match, all perfect, and you request an abdominal X-ray. Surgicals are coming, and you start some fluid resuscitation, and ceftriaxone is being prepared. Actually, sorry, you are preparing as well fluid resuscitation and ceftriaxone. But then I ask you, wait, is there anything else you want to know here? By this time in the talk, I hope we are not going to vote on that, but I'm sure all of you are thinking, I want to know the liver size before I start doing anything. Liver size actually in this case is down to the iliac crest. Okay, so maybe let's wait on this fluid resuscitation. Let me think. We have to think of the heart. We have to rethink about our fluid bolus. Maybe I still want to try it, but if I try, I'm not going to try 20 per kilo. I may try 3 to 5 ml per kilo. And I have to start thinking of inotropes, of echo and ECG. And this is just to remember, I like this algorithm. It's for sepsis, but I mean, it's really nice because it starts recognize shock, maintain the airway, and then the next thing they tell you is liver up or liver down. And then based on that, you continue deciding your protocol, your resuscitation. Okay, so because you are very familiar with cardiac diseases now, you have felt that the liver is very enlarged, the child is complaining of chest pain, you think of heart, and you do an ECG. And this is what you are seeing on this ECG. Okay, I'll let you look at it for 10, 15 seconds. You can see it's not very fast. You can see there is some broad complex. Yeah. Try to identify the P waves. You can see here some P waves. I'm going to give you some clue. So the rate is 111. PR interval, they cannot calculate PR interval. Also, the access is difficult to calculate here. And it tells you here T wave abnormality and wide QRS. So now let's vote. Let me see which one is this. So what do you think of this ECG? I'll show it to you again while you vote. So you have jet, sinus rhythm, right bundle branch block, complete AB block, no clue. I'm also going to tell you, you can see that the ST segments are not normal, yeah? They are depressed. Okay, 17 people have voted so far, 20. We have competition between complete AB block and right bundle branch block. All right. Let's see if someone else is voting. Okay, complete AB block is winning and you guys are absolutely right. This was complete AB block, okay? So let's have a look at this. So you can see that here you can see a P wave, but these P waves are completely dissociated from the QRSs. I don't see if you can see my arrow, but you see P here, probably there is a P here, but they do not, definitely this is not sinus rhythm, it's a dissociated rhythm, there is broad complex, so that heart rate is actually the ventricular escape rhythm that it's at 111. The P waves are faster and you have ST segment changes. Yeah. Okay. So this is really slightly concerning. So let's continue. You hear, when you see this, you are like, oh, shoot. I mean, I am not very happy. The next thing I would like you to vote on, if you could request one blood test, which one would be? And you have as options hemoglobin. What? Yeah, well, I think I show you the previous, the next slide, but I mean, you could have HB, white cell count, troponin, lactate, or ammonium. And massively, it looks like everyone is agreeing. I mean, some people would prefer to have a lactate, which is always a good thing to have, but a large majority are going for troponins. And actually, this, for me, it's probably quite right. Because how often it is that you see a 9-year-old with an acquired congenital heart block, I mean, an acquired heart block. I mean, it's extremely rare, yeah? And chest pain, ST segment depression, acquired heart block, all this needs to be already ringing a bell in your brain about a diagnosis. And there is one lab test, which is actually, you know, it's quite indicative of that inflammation in the heart going on, yeah? So troponin probably would be the right answer. Also, the child could have had an MI, yeah? And troponin would also be the right answer. So yes, the troponin actually, you sent that troponin and it was extremely high, okay? And you have someone, a pediatrician with an interest in echoes and around there to that day, and actually is very kind, does an echo on the baby, and they tell you how the LV is extremely dilated and extremely depressed systolic function. Okay, so now we know that what we are dealing with. Then there is a venous gas result coming back with a pH of 7.15. The child is hyperventilating with a base excess of -18 and a lactate of 5. So at this stage, your working diagnosis is acute myocarditis, history of fever for 4 days versus septic shock with bad function or potentially DCM. You actually do not know at this stage. And now we are going to vote again. Let me go to my list. So the question now for you guys is, what do we do next? Intubation and ventilation, start NIV, start adrenaline, give bicarbonate, start Albuterol, call CATS, or we cry. Okay, go ahead. So some people going for cold cut, that's always a good thing. What else? Some people are going for adrenaline. Okay, so the majority are voting for calling cats, and actually this was the right answer. However, you still have the child there. You need to do something to the baby. So this was a little tricky. Yeah, I should have said there are more than 2 answers correct. But basically what you should probably do is to call cats, because this child is extremely sick. It's an extremely high risk for an acute event happening. Yeah, you have terrible function. The child is having chest pain. You have heart block. So call cats, yes, definitely. And when you call cats, you have to start thinking this child may even require ECMO. I mean, this is more like the function of cats to think about that. But I mean, that is, you need to start thinking this is really bad, what we are dealing with. And then you must optimize the circulation. Yeah, you need to try to start resuscitating this child before you take the airway. So to start peripheral adrenaline would also be the right answer here. Okay, so that's what you guys do under CAT's advice. And I have to say, someone could have chosen NIV, and NIV would not be wrong, would not be a wrong answer. And we are going to talk about it now. However, this child is 9 years old. It's already in acute distress, agitated with chest pain. So trying to establish NIV may be poorly tolerated, and that may put the child under an additional stress that the heart cannot tolerate, and the child may actually arrest just with the agitation of going into NIV. Okay, so I would probably not do that. So, but thinking about this, why am I saying that NIV could be a potential good decision? What does positive pressure ventilation do to your heart and to your cardiac output? So this is very important concept. And actually the answer that it depends. It depends if we are talking about the right heart or the left heart. And this has to do with what we call cardiopulmonary interactions, because the heart is not floating in the air. The heart is inside the chest cavity, and the pleural and the lung pressures are transmitted to the heart. So that's why I need to think, when I'm going to intubate, what is my heart going to be? How my heart will be after that, happier or worse? Okay. And because we are dealing now with LV dilatation, acute myocarditis, very poor LV function, actually positive pressure ventilation decreases the afterload to your heart, and it's positive for the LV. And why is that? Let's try to look at this briefly. It's 50 seconds of video. This has to do with the transmural pressure of the LV. And this video explains it very well for you.
Transmural pressure is the difference between ventricular chamber pressure and the extracavitary pressure, which could be pericardial or pleural. So when we breathe quietly at atmospheric pressure or around that, our transmural left ventricular pressure, which is equivalent to the afterload that the left ventricle sees, is about the same as LV pressure. If we breathe in deeply against a closed glottis, so we perform a Muller maneuver, or even take a very deep breath in and make our intrathoracic pressure very negative, that produces, let's say, an intrathoracic pressure or a pleural pressure of -20. So the transmural pressure then becomes 140. So that deep breath, that Muller maneuver, increases the transmural left ventricular pressure and therefore the left ventricular afterload. If instead we provide a positive pressure, a positive airway pressure and a positive pleural pressure, with positive pressure ventilation, obviously, then the transmural pressure drops. So that's favorable to the left ventricle.
Okay, so that is why intubating or starting NIV on a child with poor LV function, it's actually going to be positive because it's going to reduce the afterload to the LV.
Transmural.
And this is, again, let's look at this. So imagine this child has increased work of breathing. The child has probably some pulmonary edema, is breathing against quite negative intrapleural pressures, yeah, that are being generated. Yeah, and this is increasing your transmural pressure, your LV afterload to 125. However, when I start NIV or I ventilate this child with a positive pressure of 20, this transmural pressure will be reduced to 80 and my LV will be happier. So you start adrenaline peripherally, your research drugs are ready. And then, yes, now you need to intubate this child because this child is having chest pain, is extremely unstable. You have a high lactate. You know that the LV will be happier after intubation. So you must intubate. Now, a few words about intubating a child in cardiogenic shock, irrespectively of the reason for the cardiogenic shock. Again, induction drugs are potentially fatal. Therefore, you must plan, you must prepare and discuss with your team your strategy of getting the airway and what if things go wrong. The intubation in generally is not an emergency and things can precipitate dramatically once you start taking the airway. So just take your time, be prepared, discuss, optimize your circulation. The airway must be taken by the most experienced person in the room. So that normally is the consultant anesthetist. It's going to be a rapid sequence intubation. The airway has to be obtained in first attempt. And remember having peripherally diluted adrenaline. And also it's always wise to have mini boluses of adrenaline prepared, 1 in 100,000, like 1 microgram per kilo. Yeah, so a tenth of the resuscitation dose is always good to have it ready because you don't know what may happen during the intubation. And very little doses of induction agents are enough. You always can repeat, but you know, the other way around is not possible. So my choice in general is ketamine, even a quarter or half milligram per kilo is enough in these children in severe shock with a muscle relaxant. And this applies as well for a child whom, for instance, is having septic shock with a reduced LV function, yeah? So it applies to anyone. And then remember about fluids and inotropes in cardiogenic shock. So the aim of a fluid bolus is to actually increase the cardiac output. But remember that the Frank-Starling curve, you know, if these patients with very poor LV functions, they are already kind of like here, you know, past the Frank-Starling curve. So the likelihood that you will improve the cardiac output, you will increase the cardiac output by giving volume, it's not high at all. It's actually probably very low. So you could still try when you are not very sure what's going on. If the child may have sepsis, you don't know, you still don't know. You may try to give some volume. But if there is a liver, be very in our context, yeah, where there is no leishmaniasis or you know, malaria, whatever. I mean, if you feel a liver that is very sensitive, that the heart is not happy. So then if you are going to give fluid, just do small aliquots and reassess. Inotropes, as I said, early, before intubation. I can't re-emphasize this enough. Also, IO, PIV, do not wait, do not delay anything for central venous access. And also in terms of adrenaline, just beware when you are treating a child with heart failure. If you increase the adrenaline extremely high doses, like 1 microgram per kilo per minute, you are probably not going to be helping the heart too much because you are going to increase the SVR at the same time. If you increase the SVR too much, this heart, which is also already very weak, may actually, you know, go down Yeah, so careful with the doses. Yeah, normally the cardiac doses are more like 0.05 to 0.1. Of course, when you are in an emergency, you have to go higher very frequently, but just, titrate up. Do not start like too high, because you may actually end up not helping the heart. And then milrinone is a drug that is an inodilator. It works as inotrope. It reduces your afterload because it vasodilates, so that helps the LV. And also it helps with relaxation. However, because it's a vasodilator, there is a risk of hypotension. So you need to use it in experienced hands. And normally in the A&E context, it won't probably be the right thing to do, especially because you have already a child who has hypotension and all that. Yeah, and don't forget to optimize your electrolytes as well. So this child was transferred by CATS, was rightly recognized as an ECMO candidate prior to transfer, was extremely unstable during transfer with AV block, bradycardia, runs of VTAC, ST segment sense depression, hypotension on high dose adrenaline and noradrenaline. And the child went actually directly to theater for ECMO cannulation and pacing wires insertion. On admission to the PICU, the troponin was above 10,000 with an extremely high BNP and a lactate of 20. And an MRI confirmed the diagnosis of acute myocarditis. All the viral panel was negative. We only could have the ASLO titers that were positive and C. diphtheria in the throat. The child received IVIG and was decannulated on day 8 and is, thank God, doing well today. And this was the heart after ECMO cannulation. This is the ECMO cannula, very congested lungs, very dilated LV. Okay, so just briefly, I just want to remember, all of you know about acute myocarditis, but this child, remember, that presented with abdominal pain. That initially you thought about appendicitis as the first diagnosis. So it's very frequent that they present initially with non-specific viral illness, and abdominal pain and vomiting is common, not only because of gut ischemia, but also because hepatomegaly developing very rapidly, that pushes the capsula, the liver capsula, and that is very painful. So abdominal pain is actually quite frequent in children with acute heart failure. So beware of that, okay? And again, you can have syncope, you can have all sorts of arrhythmias, heart block, chest pain, an ECG looking like MI, and you can also have sudden death with acute myocarditis. And it's one of the most common reasons for heart transplantation in children. Okay, breathe a little bit because we are just going to do the third case. So this is a 14-year-old with autism with 2 days of fever, presents to A&E with increased work of breathing. This was a case just last week. The sibling had COVID 7 weeks ago. The child is saturating well on 15 liters of oxygen, tachypneic 26, and with moderate increased work of breathing. The child is tachycardic, peripherally cold, slightly hypotensive, and with a temperature of 38. You have a base excess of -6, a lactate of 4, very low sodium, potassium of 6, and you do all your initial bits and you request an X-ray as part of your assessment. Actually, I forgot here to mention that the left lower lobe basis, you think that it's the sounds are decreased there. You request an X-ray, and in the attempt to lay the child flat, the child has a sudden bradycardia, the heart rate drops to 75, becomes very agitated, and the neck veins are engorged. So this is the X-ray. You manage to do the X-ray in a sitting position. So what does this X-ray show us? Maybe the heart is enlarged. There is some pleural effusion, some consolidation probably here, maybe in the left lower lobe. And actually, I don't know. And then you think, okay, with this that has happened, the child cannot lay flat. The child is quite tachycardic. I forgot to mention, you are not very sure if there is a liver or not, but you think this is something funny. These veins are very engorged. I'm going to request an echo. And this is exactly what happened. I mean, the A&E people got a fast echo on that day. And this is what you see here. So you see a massive pericardial effusion, yeah, with collapse of the right cavities. Yes. And now my question to you, what do we do with this child? Shall we intubate the child? I'm not going to vote because in the interest of time, but just reflect on that. Okay. So actually, we did have the voting. No, but I don't have the question in Slido, so we can't vote. So in any case, would you intubate this child to do the pericardiocentesis, or you would wait, or would you transfer? What would you do? So the answer to my question here has again to do with cardiopulmonary interactions. And that what does positive pressure ventilation do to your heart? We have seen before that for the left heart, that is favorable, but what happens to the right heart with positive pressure ventilation? So that is not that good for the right heart, because actually when we start ventilating the child, the preload will drop, yeah? So it's not, and actually the afterload may also increase. So not that positive for the right heart. And we see here on the echo that the right heart is struggling, yeah, to feel. It's quite squeezed by this pericardial effusion. So just think about this. When we are breathing with negative pressure, yeah, so how does the right cavity feel? So it feels passively through a pressure gradient from the systemic veins and the right atrium. Okay, so the pressure in the veins is higher than the right atrial pressure, and that's how the venous return feels the right side of the heart. Yeah, so in inspiration, yeah, in normal ventilation, then there is increased feeling of the right side cavities. And the opposite happens with expiration. However, imagine that we have a lot of fluid around the heart that is compressing the right atrium and the right ventricle. Then the feeling is already impaired. So imagine if on top of that, we add positive pressure ventilation, then the risk of this child actually collapsing because of zero preload to the right ventricle is extremely high. And this is what happens. And that's why you do not want to intubate these children, you know, as much as possible. You should avoid it, because the risk of, you know, having a cardiac arrest for zero preload to the right heart is really high. Yeah, and this also is what happens when the child tries to lay flat. The abdominal compartment pushes into the chest, and already the child became extremely agitated, and a sudden bradycardia developed. So really, you should avoid intubation. You should allow this child to be breathing on its own, even if it's very scary. And also the important, another very important concept here for the tamponade is that the ventricles, the right ventricle and the left ventricle work together inside of this chest cavity. And the contractility of one cavity and the dilatation of one cavity actually impacts on the other one. So if you have an LV that is impaired, then that affects the RV and the other way around. And if you have an RV that is extremely dilated, then the septum will shift to the left and will squeeze the left ventricle, and that is not good for the cardiac output. So that is called ventricular interdependence. And with tamponade, we have the maximum example or the maximum display of what we call ventricular interdependence. So what happens normally, like imagine you have all this fluid around your heart that it's compressing and it's not allowing the right ventricle to fill freely. And the pressures in both cavities become equal, yeah? So in inspiration, like self-ventilation, yeah, in inspiration, there is more flow, yeah, negative pleural pressure, there is more flow filling the right ventricular cavity. And then the septum, because all this is compressed between, you know, around this massive amount of fluid, the septum cavity shifts to the left side and squeezes the left ventricle during inspiration. And actually the cardiac output drops, the blood pressure drops in inspiration, and the opposite happens during expiration. In expiration, there is less filling to the right cavity and then better output of the left ventricle. And if you can see here, during inspiration, because there is more blood filling the right ventricle, the septum squeezes the left ventricle and my blood pressure actually drops. And in expiration, I can see that my blood pressure improves. So this is an exaggeration of what normally happens physiologically, yeah, but this is much more dramatic, and this is called pulsus paradoxicus. Okay, and actually when you do echo on these children, and this is the true echo of this child of last week, you can see this ventricular interdependence by looking at the TR inflow, the inflow in the tricuspid valve, and comparing that to the inflow in the mitral valve. So if you can see here, during inspiration, we are looking here at the tricuspid valve, there is more flow going through the tricuspid. And at the same time, there is less flow going through the mitral valve because the septum is squeezing the left ventricle because the RV is filling. And the pressures in both right and left are the same. So the only thing that we can do to fill the heart is to shift the septum to the left. And during expiration, there is less flow filling the right ventricle, and that correlates with more blood pressure through, more flow through the mitral valve. Okay. So what we can do for these children, we can only give oxygen, give volume, because you need to try to fill the heart. The problem is that the heart, it can't be filled. Give volume, maintain spontaneous ventilation whenever possible, keep the child sitting up, and perform an emergency pericardiocentesis. This should be done by an experienced anesthetist because we want to aim for conscious sedation. We just want to sedate the child so the child tolerates the procedure, but without doing positive pressure ventilation. So we will titrate the sedatives slowly, ketamine, propofol, but I mean, just small aliquots so the child self-ventilates through the procedure. And this is exactly what happened. So the child had a pericardiocentesis at A&E, and they removed, I think, 10 mL of serosanguinous fluid. That was enough for the child to be transferred safely to GOS. No one intubated the child. And on arrival to the CICU, there was a pericardial drain inserted and 800 mL of fluid were drained, but the child was kept all throughout self-ventilating. This COVID serology was negative and the PCR as well, and the child is today doing well. I don't know if there is time for a last case. We have 4 more minutes. Shall I stop, Linda?
No, why don't you maybe just quickly do your case?
Okay, so let's do this 4th case. It's really, it's just mainly about thinking of the diagnosis. It's not really so much about management. So this was a 14-month-old girl with a 6-week history of poor feeding and respiratory distress, who presents with a 1 week of worsening grunting, lethargy. The child had stopped crawling and swelling around the eyes. The child was seen by the GP, and the GP was shocked, thought that this child looks emaciated and very distressed, so gave salbutamol and sent the baby to A&E. And on A&E, the child was very grumpy, pale looking, grunting, tachypneic, tachycardic, with a poor peripheral perfusion, maintaining the blood pressure. And when you listen to the child, you think that there is a gallop, and you are not very sure about the child also having a murmur. However, very well, you think about, okay, I'm not very sure about this, what's going on, it may be hard, I feel the liver, there is a massive hepatomegaly. And you put the child on Optiflow. This was the initial gas with slightly, -5, lactate of 2.4, nothing very crazy. But you do an X-ray. I'm sorry, just ignore the tubes because this was very similar to the X-ray before intubating, but this was the heart. So massive heart, very terrible lungs with full of edema. So you are like, oh my God, what is going on? This may be a DCM, and actually someone with an interest in cardiology does an echo in A&E and sees a very dilated LV with terrible function. You give furosemide, you call CATS, and the child was retrieved to Brompton. And your diagnosis was probably dilated cardiomyopathy because this has been going on for weeks. The child is, severe failure to thrive, weeks of lethargy, no crawling, So it's not something acute in the last 1 or 2 weeks. So you could have considered for this transfer NIV, as we said before, that will help your afterload. However, you have to always think if the child will be comfortable or not, because you don't want to agitate these children at all. They are at high risk of arresting. You could have considered for transfer low dose adrenaline or milrinone because the child had a very good blood pressure still. So you could have decided to start helping the heart with some inotropes or some inodilators. And just be aware that these children, even inserting a peripheral cannula, just minimally increase of SVR by crying can precipitate cardiac arrest. So intubation is better to be done in a place where there is backup ECMO. Yeah. So I think the right thing was done for this baby was to transfer the child as fast as possible. to a cardiac center. And the echo here showed this terrible heart, very dilated, that was barely moving, extremely scary, with contrast inside, dilated hepatic veins, and mitral regurgitation. Does anyone know the diagnosis or could think of the diagnosis at this stage, 14-month-old? So this is the ECG. And in the interest of time, I'm just going to show you. The ECG here shows very deep Q waves in anterolateral, yeah? I mean, like V5, V6, yeah? This is showing ischemia, infarction. Do we have the diagnosis yet? Okay, so this has to make you think of Al-Kappa. Okay, this is the the Al-Kappa comes from like the left coronary, anomalous origin of the left coronary, which instead of coming from the aorta is coming from the pulmonary artery. Okay, as you can see here and as you can see here. So the physiology briefly. So this child was actually this child came safely to the Brompton, but after 2 hours of admission, the child arrested and went on ECMO in ECP, so ECMO CPR, and was operated the same day and is currently doing well. Just briefly about Al-Kappa, 1 second. So when the babies are born, because the pulmonary pressures are high and the PVR is high, there is no ischemia to the heart because there is still flow through this coronary artery, that the main coronary artery that is coming from the PA. However, as PVR drops, the flow through the Al-Kappa starts to revert, and then ischemia starts to develop. And that's why they have, you know, dilated cardiomyopathy type of picture. And that's why they have MR, because they have infarction of the papillary muscles, and also because the heart dilates massively. Okay, so beware of this diagnosis. Look for ischemia on ECG, and careful with these infants that are labeled as asthma or bronchiolitis, because they may have heart failure signs. So just think about this. And if there is a murmur consisting with MR, that is probably Al-Kappa. Teaching point, take home message: with a sick child, time flies. Hepatomegaly, heart, optimize circulation first. Tachycardia with HD compromise, this is shock. Cardiopulmonary interactions, positive pressure ventilation is good for your LV, and the opposite for your RV. Cold cuts soon, and sometimes the safest thing is to retrieve to an ECMO center. And thank you very much, and Merry Christmas.
Thank you very much, Angela, for that excellent presentation. If I can get you to unshare your screen, that would be great. Thank you. There were a couple of questions, Angela, as you were talking about your first case, and I'd just like to quickly ask you if that's okay while I'm putting up the feedback screen. So the first question was, thinking about the child with the SVT, is Brugada criteria clinically useful for these children, or would you just advise to go ahead and cardiovert and see what happens?
Cardiovert, I mean, definitely. Well, you need to understand, but the only thing is that the algorithm is clear. I mean, the child is in shock. You have a fast rhythm that is very regular. You don't know if that may be VTAC or that may be SVT with broad complex. Cardioversion, if there is a pulse, you should go for cardioversion. If there is, of course, if there is no pulse, then you have to just defibrillate. But cardioversion would be the way to go.
Okay, great. And then one other question for you was, if you think that the child might have low Parkinson-White and they go into atrial fibrillation, what would you do? If you think that the child has got WPW, would you give adenosine if they come in SVT?
So if you have already, let's say the child is already diagnosed with pre-excitation and the child comes with SVT, again, I would just keep it very simple. The algorithm doesn't really tell you anything about the child having both Parkinson-White or not, or they only tell you stable or unstable, fast or slow, narrow or broad. So even if the child has known Ward Parkinson White, if the child is unstable, then you have to cardiovert. If the treatment for AFib, acute AFib, would also be to cardiovert. So you will never be wrong by cardioverting. You can give adenosine if that doesn't delay things. That is fine. You can give adenosine because sometimes you will also, cardiovert chemically. That's also okay. The important thing is not to delay. And if the child develops AFib after adenosine, then the next thing probably will be cardioversion if you have given adenosine, and the reason for the developing of AFib is adenosine. So always cardiovert. That will never be wrong. I mean, just go to cardioversion. Tiny bit of ketamine, 0.25 of ketamine, 0.5 of ketamine, cardiovert. The child tolerates, will not remember.
Perfect. And on that note, actually, somebody just got a question about ketamine and the lower dose that you're advising. I mean, I understand what you're saying, but maybe just for the wider group, if you don't mind just explaining your reasoning behind suggesting the lower dose. I think Basker said, is it not cardioprotective and it causes blood pressure to go up? So why would you advise to lower its dose? Maybe just worth talking about that.
So the reason why in general in CATs and in most ICUs we are quite pro ketamine is because, I mean, there are two drugs that are really cardioprotective in a way. One would be etomidate. Etomidate is a drug that is it's an induction agent that is commonly used in cardiac units. However, there's a little bit of a problem because of it can cause adrenal insufficiency, acute adrenal insufficiency, and it's not recommended in sepsis. So that's why in A&Es, you should really not use etomidate, despite children are very stable through the induction when you give etomidate. So ketamine is the second most safe, like the second safest drug to use. And it is cardioprotective. I mean, the sense, I mean, it's just, it doesn't drop your blood pressure massively. It doesn't vasodilate you. It's not particularly toxic to the heart. It also maintains self-ventilation frequently, like for procedures like pericardiocentesis could be good. So, and it's very rare that you would see the blood pressure actually going up with ketamine. What you can see sometimes if a child has been, with a catecholamine surge, like endogenous catecholamine for a long time, you give them ketamine, they actually arrest. I mean, that can also happen. It's not like it's always safe. I mean, any agent that you give is there is a potential of having, a cardiovascular collapse in children in shock. But I mean, on and on, Linda, what would you say? I think ketamine is the safest choice.
Yeah, no, I agree. I think it's the safest choice, but the reason behind sort of using the lot or trying to avoid using the larger dose is exactly what you're talking about. Often these children are already at their maximal cardiac output from a heart rate perspective and also from a contractility perspective. And there are lots of case reports of patients being given sort of big doses of ketamine, having that catecholamine surge, and then it actually causing worsening heart failure. And as a result, that's when you get the that's when you end up with significant hypotension, possibly leading to a cardiac arrest.
And also because you have already low cardiac output, most of these children are already lethargic. I mean, it's not that they are like completely awake, and you also develop it as an experience. I mean, anesthesia and all that is also a little bit of like having your own recipes, but what I can guarantee you based on my experience and many other people's experiences that have taught me as well is that it's much better to titrate. Start small and titrate up. You can always give more. If you give a lot at the beginning, then the risk of then not being able to revert the situation and be in trouble is very high. And you will see that tiny dose of ketamine in these very shocky children that are at very high risk of, arresting during intubation makes it, the children are fine. They are not going to remember anything. And
it's also just worthwhile thinking about also how long it takes for the ketamine to work. So just making sure that if they've got already that significantly lower cardiac output than usual, it is going to take a little bit longer, and just being aware of that when the induction drug is given, that you will just need to be a bit more patient with administering the drug and getting the effects that you expect. And no, Seema, we very much just suggest ketamine as a single agent, and that's the same even for patients with sepsis as well. There's very, very few indications, I think, other than maybe patients with high ICP for giving both, I think.
Yeah, remember your main goal is to have an output after the intubation, not to have a child who is very well sedated. Yeah.
Okay, great. Thank you, everybody.
Thank you very much for your time. Bye-bye.
All right, bye-bye. So everybody, what we're going to do now is it's 11:10. I'm just going to give everybody a chance to have a stand up, run around the room, and then come back. And if you come back at 11:12, my colleague Maeve O'Connor is going to be doing the next presentation on duct-dependent congenital heart disease. Thank you very much, everybody.
Morning, everybody. I hope you've had a good run around the room in the 2 minutes that was allotted to you by Linda. Right, this will be an interactive session as well, and every so often you'll see one of these pop up when we'd like to ask you to vote. The next slide is not appearing. Okay, so I'm going to talk about cyanotic congenital cardiac disease. And it's quite a big topic to cover in an hour. So it won't be an exhaustive list, but we will look at some of the lesions. But essentially, people get quite worried about babies that are blue. And people get particularly worried because they're not sure whether they should try to turn the blue baby pink or not. So we'll talk about that a little bit. The other thing to remember about children that are blue that is not necessarily always a cardiac lesion. So we'll look at some of the other reasons that children can be born blue or go blue, and how to differentiate between what is a cardiac lesion and what is something else. Which brings me on to the cardiovascular examination. I think that's something that's really important, particularly when you're phoning Angela or myself or any of us looking for a CICU bed. And a lot of the time, it's not necessarily the easiest thing to get an echo. So look at some of the things that are really important to be able to tell us over the phone so that we can decide if it is a cardiac lesion or it's something else. And also to help us decide how fast we need to move the baby. I'm also going to talk a little bit about prostin, when you should give it, when you should not give it, some of the things that it can make worse, and some of the problems that it can cause, and a little bit about prostin pharmacology. And I think the other thing that's probably important to tell you about is what to do with the baby while you're waiting for a CAT team or while you're waiting for a cardiac bed. Right, this is the ideal situation. You have an antenatal diagnosis, you know exactly what the lesion is going to be, the antenatal genetics have been done, the parents have been cancelled, what to expect, and the delivery is a planned delivery. with all of the team around waiting to manage this baby. Echo is easily available to you, so you can get a postnatal echo and confirm the diagnosis that was made in utero. You're able to do a good clinical assessment. You are able to contact cardiology really easily and discuss the management of the baby with them. You probably already know what you're going to do because they'll have told you. You know whether to start the baby on Prostin or not. And there's a CATS team readily available to transfer the baby to an appropriate cardiac bed. That's the ideal situation, and I think that everyone by and large is fairly comfortable managing a baby like that because you will know what to do. But we're frequently confronted with something that isn't an ideal situation. So the mum may not have had any antenatal care at all, or very limited antenatal care. The diagnosis may have been missed, and you have an unplanned delivery, and you get a surprise presence of a blue baby with lots of diagnostic uncertainty. And you'll find that things like this tend to happen, sod's law, on the Friday night of a bank holiday weekend, and you can't get an echo overnight, or you can't get it all weekend. And then you think, well, now what am I going to do? So I think quite a good place to start is by looking at the fetal circulation. So if you look at a baby like this in utero, let me just get a pointer up. You're going to have oxygenated blood coming in here. The saturations and this oxygenated blood will be about 80, and that's coming from the placenta. So that blood will then go into the right heart, and not very much of it will go through the right heart and up through the pulmonary artery. The vast majority of the blood will shunt across the patent foramen ovale, and then mixed with some deoxygenated blood, which is coming back with SATs of about 25 from the head and from the body. And then those two types of blood will mix. So you'll get relatively deoxygenated blood going to the head here, with SATs of about 65. And then some even more deoxygenated blood, because the lungs aren't working, going through the duct and being distributed postductally. So the head is protected in the fetus, and it gets the most oxygenated blood available to it. Saturations here will be about in the 50s, being distributed to the rest of the body. And then when we come on to when the baby is born, this is what's supposed to happen. The lungs will expand when the baby cries. The pulmonary vascular resistance will drop because all of those lung capillaries open up. Then we will have flow coming back from the lungs into the left atrium. Because you suddenly have a massive amount of flow coming into the left atrium, the PFO will tend to close. And then we get oxygenated blood being distributed to the rest of the baby. So how does a fetus manage to survive these saturations of 65 to the head and 55 to the rest of the body? Well, the answer is fetal hemoglobin. So the vast majority of the blood in the fetus will be HbF, and the baby will also have quite a lot of hemoglobin. A typical newborn will be born with a hemoglobin of about 18. And this HbF has a really low affinity for 2,3-diphosphatidylserate. So why are we interested in that? Well, we're interested in that because that fetal hemoglobin has a really high affinity for oxygen. So if you look at the oxygen hemoglobin association curve here, and you take a PO2, for example, of 6, normal hemoglobin will be saturated at about 60% at this PaO2, and the fetal hemoglobin will be saturated at about 80. So the fetus has a very high affinity for oxygen, or the hemoglobin does even. Right. So moving on to all of the reasons that the baby might be blue. It can be usually one of 4 things. It can be something wrong with the child's brain, something wrong with the airway, something wrong with the lungs, and it can be cardiac. And it can also be something out of left field and something that no one's expecting. And I'm mentioning this because we had just such a referral in August of this year where the child came in 4 weeks old, a very interesting shade of blue, but otherwise well apart from some diarrhea that had been ongoing for a week or so, and some nappy rash. So the parents brought the child in, and a blood gas was done, and the methemoglobin was up in the 20s. So it's not something that became sort of prevalent, even though it's still quite rare, until about the 1940s. And the reason it became prevalent in the 1940s was because that's when baby formula started to come on the market. So up to then, all of these babies would have been breastfed and therefore protected. But if you make formula with water that comes from a well in a rural area that may be contaminated with nitrates, babies that are under 6 months old are quite prone to developing methemoglobinemia for a variety of reasons, but the chief reason is that they're very deficient in cytochrome B5 reductase. We have about 50 or 60% of normal adult amounts, and that's the enzyme that converts the methemoglobin that we all form back into normal hemoglobin. So the first suspected case was in Iowa in 1945. The first published case was in 1947, and there's still scatterings of these babies started to appear carrying on into the 50s, and it's still something that we see every so often. So it's well worth thinking about if you've got a child from a rural area and you see methemoglobin on the blood gas. Could it be something wrong with the brain? So it's important to do a good neurological examination. Is the baby hypoventilating? Is the baby presented with having apneas? Sometimes these babies will not be stridorous, but stertorous, which is a problem with their upper airway tone. And it's important to examine the fontanelle and the pupils as well in a baby like this, because it may be something to do with birth trauma or sudden intracerebral bleed. So we'll often ask you, a baby that's having apneas, if you can do cranial ultrasound just to outrule that, because it's obviously quite important to pick up early so we can transfer them to an appropriate centre. And the other thing that can come into play in this situation as well is substance abuse by the mum that might be breastfeeding, and the baby may be inadvertently ingesting drugs that are causing a problem with neurology. Can there be something wrong with their airway? Well, that's usually fairly obvious because the baby tends to have stridor, but they may not always do. It's important to think of things like subglottic stenosis, for instance, in a baby with trisomy 21 or a baby that's been intubated for a long period of time previously. They may have laryngomalacia, tracheal stenosis, they may have a laryngeal web or complete rings. These babies will usually have lots of work of breathing. And it's important to note whether the stridor gets better or worse, or the blueness gets better or worse when the baby is crying and upset. For instance, Queen Latresia, those babies will typically be pinker when they're crying because they'll use their mouth to cry. And other than that, they're obligate nasal breathers. But your average baby with stridor will tend to get worse when they're upset and better when they're breathing quietly and nice and settled. Could it be something wrong with the lungs? This is probably by far the most frequent thing we see, something like a meconium aspiration or a sepsis or congenital pneumonia. This X-ray is an X-ray of a baby that presented at about 4 or 5 weeks old, deeply cyanosed, and the baby was found to have a congenital diaphragmatic hernia that was picked up quite late. We can get things like a CCAM, congenital cystic adenomatous malformation, or a pneumothorax, and obviously all of those things will make the baby go blue. So a chest X-ray is really important, and to be able to describe the chest X-ray when you ring us up, and have a good look at work of breathing and the respiratory rate. And hyperoxia test is also something. I'll talk a bit more about it later, but it's also quite an important thing to do, as well as an arterial blood gas if you can. But obviously that is not always the easiest thing to do on a small squirming baby. So that brings us on to the cardiovascular examination. All of these things are things that we'll ask you about when you ring us up and you think that the baby's got something cardiac wrong with it, and it's important. It's very, very helpful to us if you can tell us all of these things. So you can measure the pre and post ductal saturations, forelimb blood pressure, and make a good assessment of the pulses. And people often will tell us that the femoral pulses are good or bad or whatever they are. But it's important to compare them with the pulses in the axilla if you can, because if the baby has poor pulses everywhere, that would lead you more in the direction of a baby with heart failure or sepsis. Generally, globally low blood pressure, as opposed to good axillary pulses and poor femoral pulses, which will send you more in the direction of a cohort, for instance. As Angela has already mentioned, it's really useful if you can tell us how big the liver is, if the baby has any murmurs, and the skin perfusion is really important, in particular if there are any differentials between the skin perfusion in, say, the right arm and the rest of the body. It's important to know if the baby has passed urine and if the baby is tolerating feed, because in a baby that's obviously a 1 day old won't pass too much urine at all, but if the child is a few days old or a few weeks old, it may be a sign that there's systemic hyperperfusion going on and that there's not enough blood getting to the kidneys or the gut. It's really useful to know if the baby is dysmorphic, because again, that may give us a clue as to the diagnosis, particularly if you can't get an echo. And it's really important to listen to the baby's fontanelle as well, in case there is a vein of Galen malformation. That's something that can be missed quite frequently. The other clues, you can get quite a lot of clues from a chest X-ray. So important things to look at are the shape of the ribs and the number of them. For instance, if there are 13, it may take you in the direction of maybe the baby has got trisomy 21. Look at the vertebrae, so hemivertebrae are quite a useful thing to know about. The size and the shape of the heart. And also if you look at the lung fields, for instance, these are very oligemic looking lung fields. So that would suggest that this baby doesn't have enough pulmonary blood flow, which again gives us quite an important clue. So I think we're on to the first Slido. So I would ask you if this chest X-ray is characteristic of which lesion? Right, we've got 100% there for tetralogy of Fallot. TGA is getting a few votes as well. No one is being sucked in to think it's a truncus or a TAPPD. Right, excellent. Can you switch back to the presentation? Oh, brilliant, smashing. Okay, right. So here's our chest X-ray. And what we can see here is that this is the next one. Fine. Sorry, this is the next chest X-ray. And I'm going to get you to vote on this one as well. Okay, this has been called a tetralogy of Fallot by absolutely everybody. We've only got 7 people voting. I'm still thinking this is tetralogy. Yeah, something's gone wrong here. I think you've not mixed up. The reason the chest X-ray. Okay, watch. Okay, I think those chest X-rays are, I've gotten quite mixed up with the questions. So can you just put me back to the presentation? Right, right. Apologies for that. So let's just talk about characteristic chest X-rays. So the one that looked like this, snowman in a snowstorm, that's really characteristic of a supracardiac TAPPD. The reason for that is that the veins get obstructed as they try to drain back into the heart. So you get this characteristic sort of bulging up here. You won't always see it in them, but it's really useful if you do. This chest X-ray here, and I did put up an example of it, this is a very much a boot-shaped heart. And you're missing the characteristic aortic knuckle because the aorta is overriding the VSD, so it's not where you expect it to be. And you also get a very hypertrophied right ventricle, so that tilts the whole heart up in its axis, and it tends to look a bit like a boot. This one here is very characteristic of a TGA, and it's sometimes called an egg on a string. The reason it looks like this is you don't get the normal mediastinal shadowing up here because the orientation of the great vessels is not as it would be in a normal child. And this one here is very much characteristic of an Ebstein's. Now, it could be a really bad dilated cardiomyopathy, and it could be a massive pericardial effusion. If it was a pericardial effusion, you'd tend to expect it to be a bit more water bottle shaped. But this is very much what you would see in an Ebstein's baby because of the size of the right atrium. Right, so moving on to the hyperoxia test. The initial, the general idea of this is that if you've got a baby with cyanotic congenital cardiac disease, turning up the oxygen isn't going to make any difference to them. It shouldn't make any difference much to their PaO2. If the baby's got a very bad lung problem and you turn up the amount of oxygen that you're giving them, then their PaO2 should improve. with the idea that giving more oxygen will overcome the degree of VQ mismatch that you're having. It won't always work like that. If the baby has got very, very severe ARDS, their PaO2 may not improve at all. But by and large, the general idea of this is that it will improve if it's not cardiac. It doesn't always work. It's not completely foolproof, and it depends on where you read it, how much the PaO2, the criteria for how much the PaO2 should rise actually are. But it's quite a useful thing to have done if you're calling us up about it. It's not completely foolproof. There are case reports in the literature where the child has had a congenital cardiac problem and it's been missed even though they've done a hyperoxia test. And here's one such example. This is a baby that was born with cyanotic spells, had a normal chest X-ray, normal ECG, but so they didn't proceed to do an echo. They did do a hyperoxia test and the PaO2 did go up. And then a few days later, the child became progressively more and more lethargic, jaundiced, and then developed hepatomegaly. So they repeated the chest X-ray, did an ECG again, and then eventually did an echo. And this baby had an infracardiac TAPVD. So it won't always tell you everything, but it is a useful thing to do. Moving on to ECGs. You don't have to do an ECG. They are useful sometimes, and they can give us some important clues. For instance, if you rang us up and said that the child has a boot-shaped heart, they go bluer when they cry, and this is the ECG, well, then that would very definitely lead us in the direction of a tetralogy of Fallot. This is an ECG with right axis deviation and some very peaked P waves here where the asterixes are. But by and large, it's not necessarily going to be diagnostic unless you have a baby, for instance, with an L-kappa. The pre and post ductal saturations are actually really, really important. And if you can't tell us anything else, this is one of the most important things to be able to tell us. If you can't measure both, what I would suggest you do is put a SATS probe on pre-ductally and post-ductally, and then switch the cable between the two. It's not as good as measuring both at the same time, but it is a useful thing to do. And sometimes we do this when we're retrieving these babies, because obviously we don't have an echo available to us in the ambulance. It gives you quite a good idea about what direction the blood is shunting in, if there is a shunt. And it also gives you quite a good estimate of what the pulmonary pressures are, because without an echo, you can't estimate what they are. But what you can do is measure the blood pressure on a non-invasive cuff. And then depending on whether the pre or the post ductal sats go up and down with intervention, it will give you quite a good idea as to what the PA pressures are. So it can be extremely useful. It can also be extremely useful in terms of guiding a diagnosis. So we've got another slide out here. If you have higher post-ductal saturations than the pre-ductal saturations, that will lead you in the direction of a particular diagnosis. So can I get you now to vote this one is working as to what you think this is? $15 people voted. Any more? Okay, so TGA seems to be winning, but all of the above is gathering support. 30 people, right, okay. So the answer is that it is all of the above, or it could be all of the above. The reason you get higher post-ductal saturations in a TGA is because you have this oxygenated blood coming back into the left atrium and then making its way out through the pulmonary artery as opposed to the aorta. And that oxygenated blood will then go across the duct and appear in the aorta post-ductally. So that's the most common lesion that you'll find higher post-ductal saturations in. You can get it in the other two as well. So this is a Tausig big heart. So double outlet right ventricle with a subpulmonary VSD, by which I mean the VSD sits under the PA. So you get, again, oxygenated blood coming into the left atrium, then into the left ventricle. And it's quite easy for it to get out here, go across the duct, and then appear post-ductally. And the other lesion is a TAPVD, a supracardiac TAPVD. Again, you have oxygenated blood that can't get into the left atrium in this case, and it's going across this aberrant vessel into the SVC, and it tends to stream downwards, whereas the blood from the IVC tends to stream across the ASD. This blood tends to stream downwards into the pulmonary artery, and if there is an open duct, it will go across the duct and appear postductally. But that's pretty unusual. When people talk about cardiac lesions, generally, they tend to talk about right-sided lesions causing you to be blue and left-sided lesions causing you to have low blood pressure or no blood pressure. But when we talk about congenital cyanotic lesions, I find it's easier to think about whether there is or there isn't enough pulmonary blood flow. So you may have no pulmonary blood flow or not enough pulmonary blood flow. You can have mixed lesions where the amount of pulmonary blood flow can be quite variable. And then the third type is lesions where you have pulmonary blood flow that's going round and round in circles, what I call pointless pulmonary blood flow. So let's look first at lesions where there's not enough pulmonary blood flow. So it could be anything that causes right ventricular outflow tract obstruction. So for instance, a tetralogy will have a degree of pulmonary stenosis, or you can also get a baby with just isolated pulmonary stenosis. Pulmonary atresia, that will obviously then be duct-dependent circulation. Tricuspid atresia, babies with Ebstein's, or you can get a more generalized problem, such as in a baby with Alagille's, where you have branch PA stenosis that's quite global and not just an isolated problem. So let's look at some of these lesions. Tetralogy of Fallot, I'm sure you all know what tetralogy of Fallot is. Can it be duct dependent? It's not usually, but it can be if the pulmonary stenosis is severe enough. So very occasionally we will get referred one of these babies that needs to urgently move somewhere because the PS is very bad and they've had to start Proston because the baby is profoundly cyanosed. Right, so here's the question. A baby with tetralogy of Fallot can go bluer if they are pyrexial, if they are hungry, if they are enraged, or all of the above. So voting. Okay, so yeah, no one got sucked into that one. Okay, yeah, they can go blue if they, for all of those reasons. If they're hungry, they tend to cry. If they're enraged, obviously they are crying. They'll raise their intrathoracic pressure and reduce the amount of blood that's getting into the lungs. The one about them being pyrexial, if they're pyrexial, they'll drop their SVR and they'll be more inclined to shunt from right to left. And then again, they will have less pulmonary blood flow. Right. Babies with pulmonary atresia. So obviously this is a duct-dependent circulation. I think it's important. People often say, well, what should their saturations be? And it's probably in the 80s is absolutely fine. The difficulty with Proston and 100% oxygen in these babies is you may steal blood inadvertently from the systemic circulation. So I'll just put this here to show you how big the PDA is alongside the aorta. And the duct is actually massive. And sometimes surgeons inadvertently tie off the aorta instead of the PDA when they're ligating them. And if you've got very low pulmonary pressures and you're giving the baby 100% oxygen, well, then you get too much blood coming in here through the duct. And what you'll notice is the baby will stop feeding, stop weeing, and their lactate will go up. So I think the answer to the question is whatever saturations don't make the lactate go up. Tricuspid atresia, again, will behave the same way, apart from the fact that this baby will obviously end up having a univentricular circulation. But again, this is a duct-dependent lesion. And moving on to Ebstein's, this is a really interesting lesion. So you get an atrialized right ventricle. So the right atrium, instead of the tricuspid valve here, the tricuspid valve will be down here and very, very floppy and regurgitant. You get this enormous right atrium, which gives you that picture that I've shown you on the chest X-ray. So instead of the blood going across the pulmonary artery, some of it will, but a lot of it will tend to shunt from the right atrium into the left atrium and then into the left ventricle. And we quite often get referred these babies. Here's a retrieval call that we had in the last couple of weeks. We had a 2-day-old baby that was born in East Anglia, no antenatal history of any problems. And the baby was having its routine baby check. Somebody listened for a murmur and heard a murmur and then put on a SATS probe and found the SATS were 85 and they were the same pre and post ductally. The baby had good blood pressure, they were awake and alert, and they had a normal lactate. And the echo was then sent on the PAC system to Great Ormond Street. The baby was diagnosed with an Ebstein's. So again, this is another Slido. This one is working. My question is, would you intubate the baby? Okay, so everybody's saying no. Excellent. That is exactly the right thing to do, not intubate this baby. Because if you intubate this baby, you will raise the intrathoracic pressure and worsen the pulmonary blood flow. Now, there may be occasions when you will have to intubate a baby with Ebstein's if they if they need prostin, for instance, if there is very poor flow across the pulmonary valve and they're deeply cyanosed, and you have to start prostin, and particularly in a large amounts, and the baby starts to have apneas. And a lot of the time, one problem may not necessarily coexist, and they may also have a problem with neurology or airway or lungs. But by and large, intubating them will actually make their saturations worse and not better. Can prostin make a baby with Ebstein's worse? It can do. Here's a picture of a circular shunt. And this is something that can develop in Ebstein's and some other lesions as well, but let's just concentrate on Ebstein's. So what you want to happen is for the baby to have two sources of pulmonary blood flow if you start prostin on them. So if the flow is very poor here into the pulmonary artery, you can give them a second source of pulmonary blood flow by opening a duct or keeping the duct open. What can happen in these babies, though, if the duct is too big and the pulmonary valve is very floppy and regurgitant, as well as the tricuspid valve being floppy and regurgitant, is you can get flow from this systemic pressure here, which will flow into the pulmonary artery and then flow backwards across this floppy pulmonary valve, backwards across the floppy tricuspid valve, and then go from the right atrium to the left atrium, back up into the aorta, and round and round and round in a sort of a figure of eight formation. And if that happens in your baby that you've started the prostin on, the baby will get bluer and bluer and will have less and less blood pressure. So it's a situation you don't want to get yourself into with a baby with Ebstein's. So by and large, if the SATs are 85, with or without oxygen, what we would tend to do with those children is don't intubate them, don't start prostin, and move them as fast as we can to a cardiac centre. Right, so that's sort of most of the right-sided lesions. Unbalanced circulation is another situation where the child can go blue. Because essentially what you're doing in this situation is trying to balance pulmonary vascular resistance with systemic vascular resistance. And in any of the lesions where you can have lots of mixing, the blood will always tend to go where the pressure is the lowest. So if the pulmonary vascular resistance and the systemic vascular resistance are vastly different, then the blood will tend to go from the area where most of the pressure is being developed, which is in the left ventricle, to the area where the pressure is the lowest. And you can end up, these babies having either too much or too little of one or the other of these. So by and large, those lesions are complete AVSD. That's probably the commonest one we see. And in babies with truncus or a double outlet right ventricle. And if they don't have enough pulmonary blood flow, then they will obviously go blue. What's important to remember is that pulmonary vascular resistance isn't a fixed thing. Babies will usually be born with high pulmonary vascular resistance, which then drops. So they may start off being quite blue and then turn pinker. And the other thing that can turn them pinker is by somebody giving them oxygen. If you give a baby with a complete AVSD lots of oxygen to get their SATs from 85 up to 100, what you will do is drop their pulmonary vascular resistance too much, and then they'll get torrential pulmonary blood flow and develop ultimately pulmonary hypertension. The other reason for some of these babies going blue, for instance, if you have a baby that's post-op Norwood that is growing, their BT shunt will only be 3 or 4 millimeters big. And over time, as they grow and get bigger, they'll outgrow their pulmonary blood flow. So here's a very typical case. We probably get referred at least one of these every month. A 5-month-old trisomy 21 baby, known complete AVSD, awaiting repair in Brompton. The baby's had a cough and a cold for about a week and is getting worse and has presented to the emergency department. They're off feeds and the referring hospital has now put them on Optiflow for increased work of breathing. They're treating them as a bronchiolitis. They've had some antibiotics. They're recessing and wheezy. Their SATs are 100 on Optiflow. They're in 30% oxygen. Heart rate's 170. Blood pressure is reasonable, but the skin is very, very mottled and pale looking. Lactate is 5, and the base deficit is -10. And they've done some bloods. CRP is less than 5, but the renal function has gone off. And here is this baby's chest X-ray. You can see very, very wet looking lung fields and quite a big heart. So going to get you to vote again. So I'm going to ask you what you want to do with this baby. Do you want to give fluids and antibiotics? Do you want to start CPAP and give some diuretics? Do you want to give the child a bit more oxygen? Or do you want to just leave them alone because they have a virus? Okay, CPAP and diuretics is winning hands down. Still winning hands down. Right, yeah, perfect. That's exactly what you want to do. What you don't want to do is give this child more oxygen. They definitely don't need fluids. They probably don't need antibiotics. They do need some CPAP to reduce the amount of, raise the intrathoracic pressure, reduce the amount of pulmonary blood flow, and they definitely need some diuretics. And you also need to ring us so that we can move them for you probably. I think another thing that's important to remember when you're dealing with congenital cardiac disease is a lot of these lesions are presented as discrete things if you read about them in the books. So you'll see a good description of a complete AVSD and a good description of a tetralogy. But a lot of the time, babies won't have necessarily read the book. Sometimes you can get these lesions coexisting or getting sort of a mixture of lesions. So you may quite easily get a baby with a TOF type complete AVSD. So it's important not to have just learned it off to actually understand how they all work. And then you can work out what you need to do with any particular child. Right. Moving on to pointless pulmonary blood flow. That could be one of two things. It could be a TAPVD or it could be a TGA, where you have lots of flow, but it's not actually doing what it's supposed to do because it's not getting to where it needs to go. So this is the picture of a supracardiac TAPVD where you've got these abnormal pulmonary veins and they're not going back into the left atrium as they should do. And they're moving instead to one of three places. It could be either supracardiac, cardiac, or infracardiac. This one's supracardiac. You've got pulmonary vein coming across here, feeding into the SVC. And the blood can then go one of two places across the ASD or into the through the right heart up into the lungs and then back into the left atrium again. So that blood will just go round and round and round and not get anywhere that it needs to actually go. I think people are often confused as to whether they should start Prostin in these babies or not, because they are blue for sure if all four veins are aberrant. And that's quite controversial. So it used to be an absolute no-no to start these babies on Prostin, but some centres actually do. They'll only do it in certain circumstances. So what will starting Prostin do? Well, if you open up a duct in a baby with a TAPVD, it will help you to preserve your systemic circulation because you don't have the blood coming back into the left atrium the way it normally would. Instead, it's going across an ASD. So you will get more systemic blood flow if you open a duct, and blood can get out of the PA into the aorta. But what it will also do is act as a pulmonary vasodilator. So you've got blood getting into the lungs that can't get out of the lungs. And if you give Prostin to these babies, you can actually make them significantly worse. So what I would suggest you do in this situation is actually ask cardiology, CICU or CATS what to do with the child. But by and large, the answer will generally be don't start Prostin in the TAPVD. A little bit about Prostin pharmacology. So Prostin is metabolized really, really rapidly. About 2/3 of your circulating PGE will be metabolized with a single pass through the lungs. So it's really important to give it as an infusion and not in bolus doses. And it's really important to make sure that the line that you're giving it through is quite a short line if you can possibly manage it. And that line is working, that you're absolutely happy that that Prostin is getting into the baby's circulation. I think Angela touched on this earlier. She spoke about a baby that's 4 weeks old going blue, unlikely to have a congenital cardiac lesion that's duct dependent because by and large the duct will be closed by 21 days. There are occasional case reports in the literature of it being open as late as, or being openable as it were, up to 36 days of age, but by and large, that duct will not open for you the older the baby is. So if you need to start Prostin, it's important to start Prostin as early as you possibly can. In terms of side effects, this is a Cochrane review from the last couple of years. I think in the DGH situation, you don't really need to worry about the long-term side effects of Prostin, but the short-term side effects are far more important. Principal problem we have retrieving these babies if they're on lots of Prostin, so anything more than about 10, if they start to have apneas. So if they're going on a short trip, the odd apnea is absolutely fine, but if they're going on a long journey from King's Lynn, for instance, to Great Ormond Street or the Brompton, then you don't want to put that baby in the back of an ambulance, so we'll ask you to intubate them. It can also drop your blood pressure. It can also give them a temperature. And these problems are usually, and a low blood sugar, these problems are usually more pronounced the smaller the baby is and the more premature that they are. They'll be a bit prone to apneas anyway. So these are the sort of important things to look for when you're starting Prostin. I mentioned Prostin delivery before, and this is something that we see reasonably often. So if you follow the CATS guidelines, we make Prostin up in a very dilute way. And the reason for that is because if it's going at a very low rate, for instance, 0.1 mil per hour, and if it's very, very concentrated and it's going through one of these really long lines here, it may take 4 or 5 hours to actually get into the baby's circulation. So obviously accessing these babies is difficult, but if you are going to give it through a UVC, make sure that you're giving really dilute Prostin through the UVC, the same dose obviously, but just in a dilute fashion, which you can do if you follow the CATS guidelines. And a lot of the time as well, what we find when we get there is that there's a massive load of connections because the baby needs 4 or 5 different infusions and access has been a problem. And somebody may have turned a tap the wrong way around because a lot of the time, all of these connections will look a bit like a snake's wedding. So have a careful look at all of your 3-way taps if you're giving lots of infusions to a baby that's on Prostin, and just make sure that they're all turned the right way around and the child is actually getting the Prostin. Here's this happened in the last year. This is a baby that we were referred that had a coarctation. And they had started the child on 5 of Prostin. And then done a repeat echo 24 hours later and found that the duct was getting smaller instead of bigger. So as you would do, they turned the Prostin up. And at the same time, they noticed that the baby had developed quite a significant neck swelling, which they thought might be a cystic hygroma. So we were asked to move this baby from where they were to a cardiac center, which we did. And then noticed that this was the line that the Prostin was going through, and this was the location of the neck swelling. So it wasn't a cystic hygroma, it was a prostinoma. So important to look at your lines if you're giving something that will have such an effect as Prostin will do. This is another case that I came across in a CICU that I was working in a few years ago. This is a baby that was born with pulmonary atresia and obviously duct-dependent pulmonary blood flow. And the baby had a UVC and was getting Prostin and TPN through it. And over the course of a long bank holiday weekend, the baby's belly was getting bigger and bigger, and the child was getting bluer and then developing quite a significant work of breathing. So we did an echo on the baby and found that the duct was really getting quite small. And what had happened was the UVC had tissued and all of that Prostin and TPN was going intraperitoneally. So you would think at that point, well, why has the baby's blood sugar not dropped and why is the duct not completely closed? Actually, you absorb things quite well, drugs in particular, quite well from your peritoneum. So the TPN was being absorbed from there and the Prostin was being absorbed from there as well. Obviously, that baby had to have a laparotomy. All the TPN and Prostin get sucked back out of them. And the other issue that we fairly frequently come across is people have lots of problems making up Prostin. So it's quite a confusing drug because it comes in a very concentrated form and you need to dilute it quite significantly. It also comes in 2 different forms. It comes as azalprostadil and dinoproston, and those 2 drugs have different potencies. So the stuff that we use is dinoproston, and here's a picture of it. And it comes in a concentration of 1 milligram per mil. The syringe that we'll ask you to make up is then in mics per kilo, and the dose that you give the baby is in nanograms per kilo per minute. So it's a massive dilution, and it causes lots of confusion, and it also causes quite a lot of problems, particularly if you're not used to doing it. So if we break that calculation down, what's in the Prostin bottle is 0.75 milligrams. What you want to do is take all of that and put it into a 10 ml syringe, then dilute that up to 7.5 mils, because that will give you 750 micrograms in the whole syringe, with a concentration of 100 mics per mil. What you then need to do is know the weight of the baby and multiply that by 15, which will give you 52 mics, which is roughly half a mil. And decant half a mil of what's in your 10 mil syringe into a 50 mil syringe, and then dilute that up to 50 mils in total, ideally with dextrose. And that will then give you a concentration of 1 microgram per mil in that 50 mil syringe. So if you give a mil of that per hour, that will then give the baby 5 nanograms per kilo per minute. So where have I got that number from? Essentially, a microgram is 1,000 nanograms. So if you give 1 mil an hour, you're giving 1,000 nanograms over the course of that hour. So that will give you 16.6 nanograms per minute in total. And if you divide that then by the baby's weight, it works out at just under 5 nanograms per kilo per minute. So a mil of that 50 mil syringe will give you 5 nanograms per kilo per minute, and then 2 mils of it will give you 10 nanograms per kilo per minute. A little bit more about the pharmacology of it. Essentially, it comes in 2 types, as I've mentioned. So alprostadil is PGE1, and dinoprostone is PGE2. So PGE2 is what cats use, and it's also what is endogenous to us. So it's what's produced by the placenta, and it's what's produced by the duct. And I mentioned the potencies. So you need double the amount of alprostadil as you do dinoprostone. So if you have your baby on alprostadil, it's important that you tell us that. Otherwise, when we go there, we may give the baby an overdose, essentially. Where does prostin come from? It comes from the placenta, and it's also made within the duct itself. And where does it go after birth? Well, a few things happen to it. The placenta will be gone because the baby has been born, and the baby will start breathing. So there'll be a fall in pulmonary vascular resistance, which will increase the pulmonary blood flow. And when that happens, I've mentioned already that prostin is broken down in the lungs. You get, there's an enzyme called prostaglandin transferase, which will take it, that prostin up into the cells in the lung and break it down. So essentially it's not being produced anymore, or very little of it is being produced, and it's got an increased rate at which it's being metabolized. This is quite interesting, and something that I found when I was putting this talk together. Your duct is actually programmed to stay open when you're in utero. So these blue receptors are receptors that tend to be vasodilatory. And as you approach term, you get less and less of those, and you get more and more of the red ones, which are vasoconstrictory. So when you're born, your duct is actually programmed to close and not stay open. I think I've discussed that already. But if anybody wants to read more about ducts, this is a really good article that I found, and it explains a lot of the effects that you see, a lot of the pathophysiology behind it. Lesions that don't respond to prostin, I suppose the most important one to talk about really is the TGA, where you have blood going round and round both sides of the circulation, but none of it getting to where it actually needs to be. And these are babies that we will move or try to move very, very quickly if they can't have a blue atrial septostomy where they are. And this is just a picture of a BAS happening. Occasionally we'll be referring these babies to somebody who will have tried and failed to do a BAS. And nothing that you can do with them. Prostin will help a little bit, but it won't cure the problem. The only thing that you can do with them is move them as fast as you possibly can to a center where they can have a septostomy. So I've mostly spoken about cyanotic congenital cardiac lesions, but obviously you can have ones that affect the left side as well. And here is a list of what they are. So critical aortic stenosis, that baby won't necessarily be blue. It will probably have a very low blood pressure. Coarctation interruption of the aortic arch, and then babies with hypoplastic left heart syndrome. This is something that you won't see very often, if at all, but I've added it in for completeness. There is another reason that you might want the duct to stay open. If you've got a baby with really, really severe pulmonary hypertension that's coming in for ECMO, it's very much a last ditch attempt, but if the right ventricle is more or less totally failing, we may suggest that you start Proston so as to decompress the right ventricle. It will ultimately make the whole problem worse because the baby will end up being bluer than they already were in the first place. I think that's it. Have you got any questions?
Let's see if I run on Slido. Okay, thank you, May, for that great talk. You can see if we've got any questions in the chat for you. So if anybody's got any questions, you can pop them into Slido or you can pop them into the chat. But in the meantime, what I'm going to ask you to do is just go to the, so if I can ask you to go to SurveyMonkey, and this QR code will take you to SurveyMonkey, and that will be able to provide feedback for both Maeve and for Angela for their excellent presentations today. Any questions from anybody? Any burning questions that anybody would love to know? I know she was very thorough, but if there's any questions about anything about congenital heart disease, now is your chance to ask them. So far, everybody said it's very informative, which is great. Okay. So everybody else who joined the, I think we have a question about pre and post ductal saturations, and then I'll come back to the certificates. Yes, Toby, if you'd like to pop the rest of your question in. What was it in particular about pre and post ductal saturations? Okay, so in the context of duct-dependent congenital cardiac disease, are you asking are pre-ductal saturations ever normal? For example, 100%?
Well, it depends on the lesion. What did you have in mind? So that'd be yes. So I suppose if you're thinking, so for example, you're thinking about a systemic duct-dependent lesion, so you will have pre-ductal saturations often that will be approaching 100%, particularly in something like a coarct, for example. Was there anything in specific that you were asking about? Were you talking about in the context of a TGA or a supracardiac TAPVD? I suspect that that's probably what we talk about in the context of, say, for example, a patient with a TGA or a supracardiac TAPVD. So where they're flipped, I think that's maybe what he meant. Any thoughts? So yeah, so in a coarctation, it will be common to have pre-ductal saturations that are high, and in a TGA, often that's not going to be the position that you're going to find at that point. At that point, often the pre-ductal saturations will be lower than that at that point. Any other questions?
So somebody's asking, the postductal saturations improve as the duct closes in a systemic duct-dependent saturation. So the postductal saturations improve as the duct closes in a systemic duct-dependent circulation, essentially. So as the duct closes, you will get the postductal saturations will normalize and will come back up to the levels of the preductal saturation. True. Yeah, that's true. Any other questions at all? Okay, so I think that's all the questions that we have so far. When you joined the webinar, you should have had access to register by putting in your name and your email address. If you've done that, then that will allow us to generate a certificate for you. If for some reason you've been able to join the webinar without registering, if you can please email cats.edu@gosh.nhs.uk, and that will allow us to send you out a certificate. But if everybody could help by filling out the feedback that you see on the screen, that would be very helpful. Thanks very much, everybody.